Welcome to this episode of Doctor-Patient Conversations. Today's theme is on handling emergencies, our first response, and being prepared for the unexpected. We have with us a very illustrious doctor, Dr. Sudeshna Ganguly, who has worked for 14 years in acute care, critical care, digital health and quality, and all of this focused on emergency responses and emergency rooms. With her experience and her qualifications, both from India and the US, she has done she has saved many lives and faced many challenges, including heart attacks and cardiac arrests and strokes. So let's hear from her how we can be prepared and how we can reduce harm if we know what to do when we have to do it. I bring to you the doubts and questions that arise in a patient's mind, representing Patients for Patient Safety Foundation. My name is Nadira Chaturvedi, and I hand over the mic to Dr. Ganguly with a big warm welcome to introduce herself with one major question. Ma'am, what is the meaning of an emergency? When should we be alarmed, and when should we just brush it aside as something that will go away on its own?
Thank you so much, Nadira ji. I am really indebted to you as well as your organization, Patient for Patient Safety Foundation, for organizing the doctor-patient conversation. I think this is an excellent initiative. And the fact that you're focusing on emergencies is very close to my heart, because that, as you kindly mentioned in my introduction, is what I have been doing for around the past 14 years of my career. And it's indeed a privilege to be on this platform and to talk about what are emergencies and how we can face them better, especially considering that India has a very large population and a significant percentage of them are geriatric populations. We also have the pediatric population and vulnerable patient groups such as pregnant women. And it is very important to understand for the general population, for the laypersons of the community, as to what we can define as an emergency and how do we go about managing them. So what is an emergency? Now, I'm defining this in my own way. It might not be the textbook definition, but I feel a medical emergency and/or a surgical emergency is any sudden illness or injury that poses an immediate risk to life or limb, but rather I should say life and/or limb, and which has the potential for long-term health adverse effects as well as permanent disability if not treated quickly. Where, as you said, that when should I be alarmed and when can I brush it aside? An exceedingly crucial question, I believe. To set some examples, first and foremost, anything to do with breathing difficulties, such as choking, very shallow breathing, labored breathing, slow breathing, or not breathing at all. All of these are emergencies. Similarly, circulatory issues, which includes chest pain, possible heart attacks, sudden weakness or numbness on one side, which is a possible stroke, or if you have sudden severe bleeding, all of them would be emergencies. The next big group would be loss of consciousness, any fainting that does not resolve quickly, any kind of fits or seizures. If the patient is completely non-responsive, it is an emergency. Any kind of severe injuries, such as major fractures, or injury to the head or injury to the spine, that's the neck, any particularly deep wounds or burns would constitute as life-threatening emergencies, or if you have a sudden severe anaphylactic reaction, or what we refer to as a severe allergic reaction, that results in swelling of the lips, throat, tongue, and again, not allows the patient to speak or breathe properly, an emergency. So if I am to sum up, then I should say anything which can affect our breathing, our consciousness, our circulation, in a manner such that the overall responsiveness and the functionality of the individual is obviously jeopardized, that is a medical emergency. It has the potential to become rapidly life-threatening with rapid worsening of the patient's condition, and that is beyond basic first aid. So that would constitute an emergency. And in such situations, though of course it can be very difficult, what we need to do first and foremost is to stay calm and recognize that this is something which we cannot figure out. We will now have to call in the forces. So very quickly, you need to alert the emergency response system. ensure that the patient is kept in a safe surrounding. Say, for instance, if I have a fit or a seizure, say when I'm using the washroom, that is a potentially dangerous place that can lead to further accidents. So you can safely remove the patient maybe from there, unless and until you suspect that I've had say, a neck injury, in which case you ideally should not remove the patient, but you should switch off any water sources or electricity sources that are next to the patient. I'm just giving an example. Quickly call an ambulance, and the paramedics can actually come in and, kind of tow the patient out. Tow might not be the best word, but I would say to, sort of grab the patient and take him or her to the necessary, healthcare facility for further workup and management.
Yeah. We are Indians. We would always try to see that, okay, we can manage something at home. Our parents, our grandparents, our aunts and uncles have taught us so many things that we can do in domestic. So the first thing that we as lay people try to do is do some first aid. Or, you're choking, so I slap your back, or I give you water, or you're fainting and I say, okay, take a pillow and lie down. So the very differentiation between first aid at home versus rushing to a hospital, which is my last resort, I think there's a gap right here as far as we patients are concerned. So how do I distinguish the first aid practices, or in fact, what is the first response I should do or not do? As you said, you mentioned what to do, but what should I not do to cause further harm? That I think would be our first learning today.
Right. Excellent question. Now, here is what I would do. First, let me distinguish between what's first aid and what's medical emergency. So a first aid is a situation that is not life-threatening, that needs care, but that does not threaten life or cause permanent damage. What are the examples of conditions that would, account as first aid? Say, for example, you have small cuts or bruises or scrapes. If, say, there are mild burns at home, a mild redness, a mild blister. If, I suppose I have, say, a small gum bleeding that's come from just brushing with a toothbrush, or if, say, there is a nosebleed that has come up when I was having a particularly prolonged phase of sneezing, or if, say, I have a tiny rash somewhere, that's a mild allergic reaction, or if, say, I have a stomach upset or a mild headache or fever, those would essentially be first aid. But when you see a patient having obvious breathing difficulty, if a patient is having obvious swelling around the mouth, which precludes breathing or even talking for that matter, if a patient has fainted or is non-responsive, if a patient obviously is cold, clammy, pale, such situations are not first aid. They are emergencies. And that is where your second part of the question comes in, that what do we not do? So the first thing you do not do is that you do not delay calling for help while you're trying to figure it out.
Right. So that's the question I was coming to. So you mentioned the red flags of bleeding, consciousness, cognitive or choking or imbalance, etc. Time difference. I mean, when we make the first response, how long should we wait before we call an ambulance, or how long should we wait before we go to the hospital? I mean, that would further deteriorate or help the patient if we don't know that it's serious enough.
Hey,
What timing?
I get the point. Now, if you have obvious red flags like chest pain, breathing difficulty, if you have a patient who's fainted, if someone is non-responsive, if someone is cold, clammy, and pale, if someone is choking, if someone has, swelling around this part of the anatomy, that's around the face, around the tongue, so that I'm not able to get this word out. For instance, a very, poignant red flag for the lay community would be, if you ask me that, Sudeshna, can you hear me? And if I say, yes, Nadiraji, that tells you three things. One, I'm able to breathe. It's because I'm able to breathe. That's why I've been able to get that sentence out. Second, my circulation to the brain is fine, because it's my brain which has interpreted that it is Nadiraji who's speaking to me, and she's asking me if I'm doing well. The third point is, because I'm able to understand, vocalize, and speak to you, so my circulation, which means my blood pressure, must be at a certain level which can sustain basic level of cognitive functions. That puts me into,
They ask us, what's your name? And I wonder, why is the doctor asking the name? Obviously, the patient doesn't need to say the name, but perhaps we didn't know that there were three underlying reasons when somebody just answers their name. That was really, really brilliant.
Yes.
Ma'am, what, in your opinion, are the common serious emergencies And we just hear of somebody, it can happen in the bathroom, it can happen on the treadmill, it can happen when you're driving, it could be out of the house. What are the most common items that you face? Top 3 maybe, that we could do something or learn something about it. I'll come to the preparedness after. Yeah.
Of course. So when it comes to the medical scenario here in India, and in fact globally, one of the first emergencies that we speak of are, of course, heart attacks. So I would say that the first emergency that one should be aware of is chest pain rather than heart attack. Right. Now, if I go to the hospital and I find that this chest pain was simply because, I was having, say, an inflammation around my ribs, okay? Or that maybe happened because I sustained a minor trauma and I forgot all about it, but my ribs didn't. And I'm taking this example because it can cause a lot of pain. In fact, that is one pain which probably will drive you to the hospital if it happens, because it will cause pain each time I breathe because the ribs move. But that is one of the most innocuous causes of chest pain. It does not lead anywhere. You just have to bear with it till it chooses to leave as it had come unannounced. But there are various other causes of chest pain which are quite treacherous, if I might use that word. One of them is heart attack. The second big is if I'm having breathing difficulty. All right. Breathing difficulty, say in a patient, if I already have a known background, say for instance, I'm a known asthmatic and I'm having breathing difficulty. It is reasonable to use your pumps first to see if that, obviates it. But if it doesn't, then that's a red flag. That is for someone who knows that he or she has breathing difficulty. Now we have the bigger set who have never faced breathing difficulty before. And this is the first time. Now, again, breathing difficulty can arise from almost each and every vital organ. We have some people who are trained, taught, and placed there to figure it out for you. But the emergency that should drive you to a healthcare facility, instead of trying to find a solution at home, is breathing difficulty. Third thing which I would like to mention is that which should alert the community to seek emergency medical care almost immediately is any kind of focal weakness. When I say focal weakness, I mean if my hand or my lower limb, that's my leg, if they suddenly become weak, if my speech suddenly slurs, if my angle of the mouth suddenly deviates, or if I'm not able to pronounce it. Again, you see, if you ask me, what's your name? I'm able to say, yes, Nadiraji, it's Dr. Sudeshna. It tells you that at least till now, blood is reaching my brain. I'm able to recognize you. So my occipital lobe is working. I've been able to vocalize, which means my speech area is intact. And my, pronunciation is not yet changed, which means that there is nothing really gone wrong with the part of the brain that controls these movements. So anything to do with any kind of focal weakness, slurring of speech, deviation of the angle of mouth, or any kind of disorientation. The person is awake, the person is oriented, but you're asking him, what's the address of your home? And the person says, I don't really remember. That is a red flag. That's where you stop everything and you go to the hospital.
3 top ones. It made it easier. One was chest pain, the other was breathing, and the third was cognitive or loss of balance, etc.
Yes.
Because of that statement you mentioned that if somebody's having breathing problem, it means if we have preconditions, we can be better prepared. And who should we tell, and what will be the process of being prepared for the unprepared?
Preparation is key. Now, if I have any chronic illnesses which can periodically exacerbate, then it is obviously very intelligent to stay prepared. I'm just first outlining the scenarios where we should be prepared, though all of us should be prepared ideally. But if I have preconditions, I should be prepared. If there is an elderly individual at home, I should be prepared. If I have children at home, I should be prepared. If I have a pregnant lady at home, I should be prepared. If I have someone at home with special needs, I should be prepared. So these are certain scenarios where I should be prepared. In consideration of these specific scenarios, as well as in general preparedness, there are certain things we should do. First is, of course, offline preparation. Offline preparation means our hard copy. So we can do simple things. We find out what are the 3 or the 4 maybe tertiary care hospitals that are within our vicinity. Write down their contact numbers, write down their emergency phone numbers, wherever you are located. Pin them in the most prominent places around your household, which can be on the fridge, which can be on your working station, which can be on the door of your apartment, doesn't matter. You can put it in all the places where people can see it. So that's your first step of preparedness. Next, prepare files of the patients who are liable to be patients. That is the groups which I mentioned, geriatric, pediatric, special needs, pregnancy, all of these, populations have their files prepared. When I say files prepared, what do I mean? Name, age, gender, associated comorbid conditions, diabetes, hypertension, thyroid, all of them, asthma. So mention all of the associated medical illnesses. Next is any surgeries, any implants that they might have, any pacemakers that might have been installed. For instance, I get a stroke. In all, with all diligence and commitment, you take me to the hospital. You are just not aware that I have a metal plate placed in my lower limb from a fracture which I had sustained. The good doctors there take me to MRI, and then we have serious trouble. What are the likely conditions that this patient might have? Say, for instance, if that's an asthmatic, what are the pumps or what are the medications that that person already has? So that would be a comprehensive file. You can keep e-copies of it, as well as one hard copy which can be grabbed by whoever is present with that particular individual at that point and take it along. And here, again, technology can play wonders. You can have apps on your devices, as well as wearable devices, which can not only record your data, such as your heart rate, your blood pressure, the number of steps you've taken, the blood sugar, but it can also alert you. There are, Fastbits, Fitbits, Samsung Health. So all of those have those Google Fit. They have those, wearable devices, which will sound an alert if I collapse, because it will record that my heart rate is no longer, recordable.
Really worth. So the tech items, the tech apps are worth investing in, especially.
Yes, it's worth investing. It's very, very worth investing. Yeah. So because what happens?
I would summarize chart. We call it in case of emergency. What you mentioned is your name, the doctor's name, your blood group, your main morbidity, whatever illnesses, the name of the hospital. I think that's a very wise one, because at the last minute, if you go to a wrong hospital or the nearest hospital, we may not be the right place, and we might further down. And this being what you kindly said, putting it up in prominent places, I think is key. Perhaps even leaving the keys with a neighbor or a close family person might, just help us. So whom do we call for help? What ambulances should be there? How should we explain to the ambulance people? Is there anything that we should keep in mind? And call out. Of course, if they can, depending on the congested areas, or should we drive ourselves? How do we take that decision?
Right. So it basically, as you just said, first point that I would like to mention is the nearest hospital may not be the best hospital, which is why we are preparing and getting in touch or having the contact information of the nearest tertiary care centers. The nearest hospital is good when you have a minor problem or you're seeking, an advanced first aid, let's say, if I can use that term. But when it comes to anything that has got to do with serious breathing difficulty, serious circulatory issues, or serious consciousness issues, then you would need a hospital which has a 24/7 emergency, which has 24/7 radiology, 24/7 OR, 24/7 blood bank, and 24/7 subspecialists and super specialists. So that's your first, like the cognitive, detailing of the facilities that are around you. Now it comes to how do I get there? Now, when it comes to going there, the logistic depends on whether there is someone available who can actually drive down. If not, then the best way to go about it is to have specialists coming in to basically do the transportation, because transportation is a very, very critical aspect of care. We might actually do more harm while we are transporting the patient. Hence, it is very wise to call in the paramedics, to call in an ambulance, especially when you have to shift a patient who has obvious trauma, especially trauma to the neck. We have to be very, very careful before we can move a person who has a potential or a suspected neck injury. Then a patient who's bleeding, a patient who's having breathing difficulty, a patient who's having circulatory issues. And if the patient is non-responsive, which obviously brings us to the context of layperson CPR, but maybe we'll go to that later, that we need to have the specialists actually, as I say, coming in who know how to safely transport a patient. Now, when you're calling in the forces, you have to ensure that you're giving them the correct information. The sequence in which the information should be given is location. We start with that. That's most important. when you're giving the location, please be very specific about the landmarks. Say, for instance, second floor flat, say 101, of so-and-so apartments near, say, XYZ temple. Now, give a landmark that is prominent, give a landmark that's going to be noticed and will also be known to your community. So if that ambulance drives out and says that, can you tell me where this apartment is? I was told it's somewhere near here. So if you give a landmark that's very prominent, then you are more likely to have community help also enlisted on this. Please share a phone number that's reachable. Not any phone number. A phone number where you are reachable, where you know that you'll be able to respond. Make sure that there is someone. Yeah, there's someone who's always on the phone. Next, of course, what has happened? A brief, succinct, but clear description, such as the patient was having chest pain and breathing difficulty, but is now not responding to me. Very, very vital. Very, very vital indeed. If you have done anything, say, for instance, I'm asthmatic, you have given me a spacer. So you should mention it, that I've already given a spray of the inhaler. Or this patient is someone who has known heart disease. I had nitroglycerin with me. I've given him one sublingual tablet. Or there was a big wound on the hand and I have applied a bandage, and at present it's not bleeding, but the bandage has soaked through. All of these are very, very important information. And last but not the least, the information, what is very important for us as medical healthcare providers, whether the patient is conscious or unconscious. Is the patient breathing or not? And is the patient able to respond to you? If there has been vomiting, if there has been a collapse, if the patient is confused, we do need to know, because we need to equip our ambulances accordingly. Also tell them if the patient has any special needs, such as a patient who is wheelchair bound, a patient who has domiciliary oxygen given. Say, for instance, if that patient has, say, something called an obstructive sleep apnea and has to sleep with oxygen on most of the times, that would be an important information. So the ambulance which I'm bringing in must at least have oxygen supply on it, if nothing else. So all of these are very, very important informations that you should have ready with you, and you should be in a position to provide to the paramedics who would be responding to you on the call.
Are there latest ambulances and refined or modern ambulances that carry all this stuff? I mean, one hears of air ambulances and train ambulances, but even if it's a neighborhood ambulance, would there be a particular kind of ambulance we should reach out to or know about?
Yes, because if you are obviously, in front of a patient who has breathing difficulty, who is not conscious, or who is going to need tertiary level care, then the ambulances must also be accordingly equipped. We have 108, which is a very prominently known ambulance group. But besides that, even the local ambulances who are maybe not prominently displayed, but who are available, you should tell them that you need an ambulance which is equipped with advanced cardiac life support facilities. So it should be an ACLS ambulance, which typically has an oxygen source. It has a defibrillator. It has the important drugs which are needed. They have facilities for placing an IV channel. There are facilities for monitoring the patient. And they also have facilities for connecting back to the particular hospital if they are tied with hospitals, or if they're coming from a specific hospital, where they can relay this information so that the emergency department can be prepared.
That sounds life-saving. One last question before we come to the end. You mentioned life-saving. You mentioned cardiac life-saving. There's a common confusion about CPR. Should it not? Should we not? How do you distinguish when to administer CPR, which is a very commonly used phrase these days, and a lot of school children are getting, trainings in this. But I'm sure it's not just one size fits all. Ma'am, can you throw some light on that?
Right. Perfect. Thank you for asking this question. I think it's a very socially responsible question that you have come up with. The difference between a heart attack and a cardiac arrest. So a heart attack can be a potential cause for a cardiac arrest. A cardiac arrest is I would say, a much more critical condition, or a much, I would say, higher term in respect to a medical condition than a heart attack. Why? I'll tell you. A heart attack is typically when blood supply to a particular portion of the heart is hampered, which is typically due to a clot that rests or sits in one of the major cardiac arteries, which is supplying blood to the heart. The heart is our central pump, which supplies blood to the rest of the body. But the heart itself also must get its nutrition. And its nutrition and oxygen supply, come from the arteries which are supplying the heart. So a blockage in any one of them, or sometimes even in multiple of them, precludes oxygen and blood from being delivered to the relevant section of the myocardium, that is the heart muscles. Now, this, of course, results in the heart not beating correctly or appropriately and not being able to generate the amount of blood that's needed so that, the circulation can be maintained. However, a cardiac arrest is where the cardiac activity has come to a standstill. Now, this cardiac activity coming to a standstill can arise from a heart attack. It can also arise from a blood clot within the lungs. It can also arise from poisonings and overdoses. It can also arise from me being electrocuted. It can also arise if a person drowns. So there can be many potential causes for the heart coming to a standstill. So a heart attack is... No.
It doesn't pump.
No. A heart attack, is one of the causes for cardiac arrest. But a cardiac arrest is where my heart has stopped. And as a result of which, the circulation within my system is zero. And at the same time, my body is not getting any circulation at all. And I'm also not breathing. So that is cardiovascular arrest. And when a patient, how do I recognize that the patient is in cardiac arrest? That is when the patient is obviously going to be completely non-responsive. If typically what we do is we tap here, we shake, and we speak loudly, clearly, in a language that's known to the patient, of course. So if you tap me here and you say, Sudeshna, can you hear me? If I do not respond at all, neither in terms of vocalization or any kind of movement or any kind of sound even, then I'm completely non-responsive. The next step requires very minimalistic training, I would say. The little bit of training, we can all get this done. That is to check if there is a pulse here. The pulse that we normally check for here will not work. We need a central pulse, which is in the neck. That's the carotid. So we check for the carotid pulse with tips of 2 fingers because this is the part which is most sensitive. And we do it only for 10 seconds. And while I'm doing this, I also observe because I'm, like the patient is lying down, I'm observing the patient. So I observe for any movement of breathing, any passage of air, any movement of the chest. So if I do not get a response, I do not find a pulse, and I do not see the patient breathing, that's the time when cardiopulmonary resuscitation needs to be started, which comprises of chest compressions. This is something which every single individual of the community should be aware of. There should be intensive percolation of this information and layperson CPR training so that while the ambulances arrive, and we have to understand that in a 150 crore strong population, and of course, we are one of the most progressive nations of the world, but we are still a little bit away from the point where we can have a comprehensive system that can reach us in a record time of 6 to 10 minutes. Yes. So we need to pitch in. We need to use the strength we have, and we have the strength of population. So if we can train our population to give chest compressions, then that can save life in out-of-hospital cardiac arrests or OHCAs, which are the most critical emergencies that any of us are likely to face within our lifetime. So OHCAs account for 80 to 85% of the cardiac arrests that we encounter. And because there is practically nothing being done at the community level, and we have those patients being transported in, the overall rate of re-establishing circulation or even achieving, a return of circulation is very, very dismal. So I feel that every person should at least be aware of this difference, should be able to understand and recognize a cardiac arrest, which again, as I said, 3 simple steps: no response, no pulse, no breathing. So we start chest compressions. That can really actually make a difference.
Thank you for giving us hope and a way forward. And we really appreciate the distinctions you made in emergencies, in first aid. In being prepared, everybody should now put up an ICE chart in case of emergency on your fridge. That's what the doctors are propagating, and learn CPR, because emergencies can come not just in your house where you're comforted, it can come on the road while traveling, or you are a witness to somebody else having a problem, and you can be the savior, not just for yourself, but for somebody near, dear, or unknown to you. So with that, we end this conversation with many thanks to Dr. Ganguly, and there's lots for us to take home, lots for us to do. So here's to handling emergencies, if not stopping them, preventing them, at least being prepared for them. With that, I end my health, my responsibility. That's the motto of our foundation. Let's go forward together and save lives. Thank you, Doctor, for being on.
Yeah.
These doctor-patient conversations are brought to you by 𝗏𝗏 and Patients for Patient Safety Foundation. 𝗏𝗏 is the consortium of accredited healthcare organizations established to promote quality, patient safety, and accreditation. As healthcare providers, we wish to partner with patients and educate them about the common disease conditions, symptoms, so that they become empowered partners. Towards this, we have partnered with the Patients for Patient Safety Foundation to bring to you doctor-patient conversations.
Thank you, ma'am. Patients for Patient Safety Foundation, established, as you know, by 𝗏𝗏, focuses on patients, families, caregivers, and lay people who are unaware that they can engage and provide equal partnership in healthcare outcomes. We do this by creating suitable, simple patient education material, which highlights early symptoms for early detection and better cures, including the risks and consequences if these are ignored. But there is hope because we also provide tips for actionable protection and preventing of all such harm. Towards this, we bring you this series of conversations which addresses doubts and fears that lay hidden in a patient's mind, but experts, doctors clarify these, providing well-timed information for self-engagement. We do hope you build this partnership with the healthcare providers, and remember, our health is our responsibility. Thank you, and keep watching these episodes.